So I'm sure by now you are building up on the concepts that we have learned so far in the different videos that we have covered on the channel on the ECG. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. This is my ECG Bootcamp. It's a series on my YouTube channel where we look at medical topics in depth with focus on the ECG. Today we're going to be looking at right bundle branch block. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. Like I always start off these videos, if you haven't watched part 1 to part 3, please pause the video right now, go watch part 1, part 2, and part 3, because the concepts here are going to be so strange to you, they're not going to make so much sense, and you're not going to be understanding how to do the ECG, because remember that these principles are very volatile. If you don't practice them, they disappear. I don't know why you're still here. Please go watch part 1 to 3 if you haven't watched part 1 to 3. In the previous videos, we looked at the different basics of the ECG and interpretation of the ECG. We looked at step 1, which is pretty much the patient and the ECG details. Step 2, where we determined the ECG calibration, whether it's normal or it's not standard calibration. We looked at the general impression of the ECG. We looked at rhythm determination, where we checked the regularity of the ECG, the rate, the P waves, the PR interval, the QRS complex, and an overall determination of the rhythm, whether it's a sinus rhythm or it's not a sinus rhythm. We looked at step 5 in the previous video, where we looked at determination of the cardiac axis. In this video, we're going to be looking at bundle branch block, predominantly right bundle branch block. In the next video, I will look at left bundle branch block, and then in the last video, I'll talk about the RS wave progression. And we will be towards the end of this ECG series, so please stay tuned. I hope by now you have built up on these concepts slowly. They may seem like as if they're very easy, but if you don't practice these things, you won't get the idea, you won't get the gist. So remember from our previous lectures, we already established that the heart has this property of automaticity, which produces its own action potentials. These impulses are going to be generated by a specialized type of tissue in the right atrium, which is known as the SA node. It will generate this action potential that is going to spread through the internodal tract, and eventually it's going to be carried to the AV node. Remember, when the SA node depolarizes and the current spreads over the right atrium, it causes the P wave to form on the ECG. Depolarization of the atria is going to be manifested by the P wave. Eventually, this impulse is going to reach the AV node, because that's the only place where conduction can happen through into the ventricles under normal circumstances. This AV node is going to be carrying this impulse to what is known as the bundle of His. The bundle of His is divided into two. You have the right bundle branch, and you have the left bundle branch. And remember that because the left side of the heart has a bigger muscle bulk than the right side, it's going to be divided into an anterior fascicle and a posterior fascicle. So remember that if the current is actually flowing through these pathways in a normal manner, it means that even the ECG is going to appear normal. If the current is not flowing through these pathways in a normal manner, it means that there'll be a problem with the ECG. And remember that if you have the ECG or you have the waves on the ECG being initiated from the SA node, most likely your QRS complex is going to be narrow. If it's coming from the ventricles, or if there's a problem in the conduction system, it may cause your QRS complexes to become broad. So remember that there can be a blockage in any of the bundles branches, whether the right bundle branch, there can be a block in the left bundle branch, and this will cause an abnormal flow of the current, which we can be able to pick up on the ECG. It's very important that you actually pick these things up, because, for example, if you have a right bundle branch block, it can make interpretation of your ECG very difficult to do. If you have a left bundle branch block, it may make it even almost close to impossible to further interpret if you have a left bundle branch block, which is why you have to pick up some of these pathologies. So remember that once your depolarization is going to be reaching the interventricular septum, normally this is going to be, of course, denoted by normal waves and timings and intervals on the ECG. So the interval beginning from the beginning of the P wave to the QRS complex is what we refer to as our PR interval. If this is within the normal duration and within the normal confinements and the normal timings, then the PR interval is going to be constant and it's going to be normal. So remember that your normal PR interval is between 3 to 5 small boxes. Anything less than 3 small boxes is denoting a short PR interval. Anything greater than 5 small boxes, we call that as a prolonged PR interval. With prolonged PR interval, we most commonly see them with, of course, the heart blocks, the 1st degree, 2nd degree, and 3rd degree heart block. So if there's any abnormal conduction that we see in either the right or the left bundle branches, this is going to result in a delay in depolarization of either the right ventricle or the left ventricle, respectively. And remember that the extra time that is taken for you to depolarize the other ventricle because it's not receiving an impulse at the right time, this will cause an abnormality in our QRS complex. So it means that there's going to be an abnormality or widening of the QRS complex. Remember, in a normal heart, the QRS complex must be less than 3 small boxes. It must be less than 120 milliseconds, or less than 3 small boxes. So if your QRS complex is greater than 3 small boxes, meaning it's greater than 120 milliseconds, then you should know that your conduction is abnormal and it's being conducted through a slower pathway as opposed to the normal pathway. So remember that the bundle branch blocks are not the only thing that can widen the QRS complex. If the ECG wave is actually being commenced within the ventricles, then you're going to get widening of the QRS complex. So if there's a sinus rhythm with a bundle branch block, you're going to see that the P waves will be present. I'll show you some examples. The P waves will be present and the PR interval will be constant and it will be normal. It's quite different from when the rhythm is actually beginning in the ventricle. When it's a ventricular rhythm, you're going to see this widening of the QRS complexes. So in some patients that have an isolated bundle branch block, you may actually see the narrow QRS complexes. You may not see widening of the QRS complexes. And of course, if you block both left and right bundle branches, it's almost equivalent. It's actually has the same effect as you having a 3rd degree heart block or a complete heart block. So when you talk about right bundle branch block, it's just simply blocking the right bundle branch. So this is going to mean that there's a problem on the right side of the heart. Most of these patterns are going to be seen with a QRS complex which has a normal width, and it's actually quite common in healthy people. So it may not carry some pathological implication in some people. But with the left bundle branch block, if you see a left bundle branch block, it's almost always indicates that there's some sort of heart disease. It's almost always pathological. And we usually see that there's a problem on the left side of the heart. I'll talk about left bundle branch block in a separate video. In this particular video, we will focus on right bundle branch block. Remember, it's very important to pick up these pathologies. Like I told you, left bundle branch block will prevent you from interpreting your ECG even further. Right bundle branch block will make your interpretation quite difficult to do. So what are the key things to remember before we dive into how to determine this? So number one is remember that the septum is going to depolarize from the left side going to the right side. Remember that the left bundle branch branch is going to be depolarizing first, then it's going to send impulses to the right side, and then the right side will depolarize. This is because the left ventricle has a greater muscle mass, and so it's going to be exerting more influence on the ECG and the vector. There'll be a smaller vector that is moving towards the right side of the heart. Number three is that this impulse is going to be, if it's spreading towards a lead, it will cause a positive deflection. If it's spreading away from the lead, it will cause a negative deflection. And the two leads that you should focus on when you're looking and you want to make a diagnosis of this bundle branch blocks is you want to look at V1 and V2. We also want to look at V6. Remember that V1 and V2 will be looking at the anterior part of the heart, or predominantly the right ventricle. It also looks at the septum. Then V6 is looking predominantly at the left ventricle, so the lateral aspect of the left ventricle. So that's what I want you to keep in mind. I've talked about all these principles in our first video and what these leads are going to be representing on the heart. Now is the time for you to put those principles to the test. So remember that when the depolarization is happening, you have the AV node being depolarized there. There'll be a current that first spreads on the left side. here, so it will depolarize the left bundle branch. So if you have a lead that is here on the opposite side and a lead that is here on the opposite side, remember that our initial cardiac vector is moving in that direction, but the left side is going to depolarize first. So it means that this lead here on the left side is going to be showing you that there is predominantly a wave, because this is going to be depolarizing going in that direction. So there'll be a negative wave that is seen on this lead, which is of course V6, which is on the other side. On the other aspect, this lead which is facing the heart from this direction, which is V1, will show that there's a positive deflection in V1 that is there. So because this current is spreading towards the right side of the heart, eventually to depolarize the right side of the heart, and the vector will be moving this direction. So going towards the apex of the heart, this will now cause your initial positive wave now to become negative, because it will be moving away from the leads. So eventually this is going to climb up the lateral walls of the ventricle, and it's going to be moving towards this lead V6. So you expect a positive wave in, of course, V6, and then it is spreading upwards like that, forming our QRS complex. I explained these details in the first particular lecture. So now let's talk a little bit about the right bundle branch block. So remember that the impulse is starting off at the SA node, it's spreading and it's going to depolarize the atria, and this is what we see as the P wave on the ECG. So if you don't see your P waves, it means that your rhythm is not sinus. So it means your rhythm is starting off from somewhere else. This impulse is going to then be carried to the AV node, and then it's eventually going to reach the bundle of His, which is of course divided into the left and the right bundles. So the left side will depolarize first. So like I told you, this left side which depolarizes first will send over a small current towards the right side. So this is the right side here, this is the left side. So this one will depolarize first, then send a current in that direction here. So this would mean that if the current is moving in that direction, this lead which is facing this side will show a positive deflection. So this is what is responsible for this initial R wave. And if this is moving away, the current is moving away from the left side, this will show a negative deflection. So V6 is going to show a negative deflection, V1 is going to show a positive deflection. This is the normal actually progression of the R wave. I'll talk about this when I look at the R wave on the last video of the QRS complex interpretation. When we look at the R wave progression, we shall see and explain this again, and we shall see that this is what is normally supposed to happen. So the first wave of the QRS complex, if you're looking at it in V1, which is the right ventricular lead, it's going to be positive because this impulse is flowing from the left side, the left bundle branch, to the right bundle branch. Then because it's flowing away from V6, which is representing our left ventricle, so this one here is going to show you a negative deflection. So that's what's happening in the first phase. Then eventually your impulse is now going to spread towards the apex of the heart. Remember, if it's spreading towards the apex of the heart, it's spreading upwards in the right ventricle. So it's going to be flowing towards this V6. So if it's spreading towards V6, this impulse is moving from the apex of the heart here towards V6. It will show you now this positive deflection, which is what we call our R wave in this lead V6. On the opposite side, because this is spreading towards the left ventricle first, and remember that the left ventricle is going to depolarize before the right ventricle. So it means that this impulse which is moving away from V1 will give you this negative deflection in the lead V1, which is in the right ventricle, because the right ventricle has not depolarized at this particular time. So you see an S wave in V1, you're going to see an R wave in V6. Then after this has happened, remember that here there's supposed to be, under normal circumstances, this impulse is supposed to depolarize this. Then afterwards, there's supposed to be another impulse that comes and depolarizes the right ventricle. So this S wave here is supposed to come back to baseline and continue like that. Then this R wave is supposed to also come down to baseline like that and continue. That's what's normally supposed to happen, and that's what the QRS complex, that's how the QRS complex actually forms on the ECG. But this does not happen because the right side has been blocked. So the right side, it cannot receive the impulse from the left bundle branch. So if it cannot receive the impulse from the left bundle branch, it means it will take some time for this impulse to actually reach the right ventricle, such that here now there will be an impulse that will come from the left ventricle traveling towards the right ventricle. This impulse that is traveling towards the right ventricle, remember, if it's traveling towards the right ventricle, it will show a positive deflection in the lead that is present on this side. So it will show a second positive deflection, which is due to depolarization of the right ventricle. So this is what we call our R prime wave. So we have an initial R wave, an S wave, and an R prime wave. So we see this in V1. The opposite is happening, of course, in V6. As this impulse is moving towards the right ventricle, it will show you this S wave. So you're going to be seeing S waves, deep S waves that are present in V6. You're going to be seeing this R prime wave pattern that is present in V1. Then we see that there is some right bundle branch block. So remember that your Keras complex in V1, like I said, will have an R prime wave pattern. I talked of these patterns in the first video. Like I told you, if you've never watched the first video, you will be confused here. But the Keras complex, if the impulse is starting off in the SA node, your Keras complex will be of normal width. So it's going to be less than 3 small boxes. So we can sometimes refer to this as partial right bundle branch block. And usually it's not of much significance. It can actually consider it as normal. Some people have it. Some healthy people have it. Remember, in ECG, we treat the patient, not the ECG. So how do I remember this very quickly? So remember that your Keras complex kind of looks like rabbit ears. It looks like the ears of the rabbit. So this looks like the ears of the rabbit. So you can think of it as rabbit ears, or you can think of it as an M pattern. So you're going to be seeing an M pattern or rabbit ears in V1, V2. Sometimes you see it in V3, and you're going to be seeing these deep S waves or slurring of the S waves in V6. So you're going to be seeing this S wave in V6. This here is a slurred S wave. Remember, it's supposed to be having sharp points in like a straight line, but you may see slurring in these different patterns of the S waves. Remember that the M wave that we see, the rabbit ears we see in V1, V2 is actually more important in determining whether right bundle branch block is present than the slurring of the S waves, because sometimes you may not see the slurring of the S waves. So what are some of the causes of right bundle branch block? Think anything that can damage the right side of the heart. It could be an acute anteroseptal MI, it could be an acute pulmonary embolism or an infarction, it could be an acute congestive heart failure, you could have an acute myocarditis or pericarditis, you could have hypertensive heart disease, you could have congenital heart disease. So what do we do if we find out that there's right bundle branch block? We treat the patient. Remember, we treat the patient and not the ECG. We relieve the symptoms that are there and treat the underlying cause that is there. And if you have a right bundle branch block, think that there's an atrial septal defect. So usually there's no specific treatment. So now, I will give you 3 examples that I want us to work through. So here I want you to interpret the ECG. You may pause the video, zoom the screen, enhance the quality on your video so that you can actually have a good overview of how to interpret the ECG. So you may pause the video at this particular moment. And remember, if you don't practice these things, they're not going to stick. You won't understand what is going on. So here comes the answer. So remember, the first thing that we look at is the ECG details. We don't have any ECG details here. We don't have the patient name, the date, and where this ECG was done and what time it was actually done. We look at the calibration. Remember, it should be 1 small box and 2 boxes tall. So 1 small box wide and 2 small boxes tall. So the calibration is normal. If we look at a quick glance of the ECG and look at the morphology, this looks ugly. It looks like an ugly morphology. As we can see, there is some broad Keras complexes here. They look broad. There are more than 3 small boxes. So we can't comment on the regularity of this ECG because we don't have a rhythm strip. We can't comment on the rate because we don't have a rhythm strip. So I'm not going to comment on those. Then when we look at the rhythm, just a quick determination of the rhythm, we can see that the P waves are present. So you look at lead 2 here. We have a P wave here, a Keras complex, a T wave. We have a P wave, a Keras complex, and this looks like a T wave. Then we can see that even in lead 3, we have a P wave here, a Keras complex, what looks like a T wave. So we could see that the P waves are present and they're normal width. The PR interval, if you count very closely, zoom your screen and count very closely, you see that it's about 3 small squares and it's constant. Your Keras complexes are broad. You can see even this one in lead 2 is quite broad. Even this one in lead 1 is quite broad. So it's more than 3 small squares. So it's a broad Keras complex. So we look at our cardiac axis. Remember our lead 1, the Keras complex is facing upwards. Lead AVF, the Keras complex is facing downwards. So that's left axis deviation. So if we check if it's significant, look at our Keras complex in lead 2, which is facing upwards. So it's not really so significant. So you can see that this person has a normal cardiac axis. We look at then our Keras complex in terms of looking for any bundle branch block. So we look at V1, V2, and V6. So we look at V1, we can see that there are these rabbit ears. There's a QRS pattern. Even here there's a QR, or rather there's an RSR prime, not a QRS. RSR prime in V1, in V2, we also see it in V3. In V6, we can see that there is some slurring of the S wave, or there is this S waves that which are slurred in V6. When you look at the RS wave progression, remember lead 1 is supposed to be facing upwards, lead 2 is supposed to be facing upwards, lead 3 should be facing upwards, the Keras complex in lead AVL and even AVF is supposed to be facing upwards. All of them should be facing upwards, but we can see that our Keras complex in lead 3, even in lead AVF, are facing downwards. So this is a poor RS wave progression. Another way in which you can tell the RS wave progression is looking at this precordial leads. So your V1 is supposed to be facing predominantly downwards, V2 Keras complex downwards, V3, V4 should be almost like equidistant, so equal R and S waves, and then V5 and V6 should be facing upwards. So there is a poor RS wave progression. I'll talk about the details of the RS wave progression in another video, probably after we do the bundle branch blocks. Then you should be able to understand what I'm talking about. But for now, know that there's a poor RS wave progression. So what do we have on this ECG? Number 1, we have a sinus rhythm. Number 2, we have broad Keras complex. Number 3, we have a right bundle branch block. So most likely this patient just had an isolated right bundle branch block. As we can see, even the cardiac axis is pretty normal and not so significant. Moving on to the next one, interpret the ECG. Like I said, practice, practice, practice. Pause the video, take down some notes, make your diagnosis. What are the abnormal findings on this ECG? And here comes the answer. So we can see that we don't have the ECG details, by the way. We don't have the patient's name, when this ECG was done, where, and the file number. The ECG calibration is normal, so 2 big boxes tall and 1 small box wide. Here we do have the rhythm strip here from lead 2, so we can comment on that. So our general impression is that there are these ugly morphologies that we can see of the Keras complexes, especially in these lead V1 to V6. If we look at the regularity, remember we can map out a paper from, or you can measure the distance from this Q wave to this Q wave, then move with 3 consecutive waves. You can see that it's regular, the distances are the same. A quick assessment of the rhythm before we come to calculate the rate, we can see that there's a P wave that is present, a Keras complex, a T wave, a P wave, Keras complex, a T wave, a P wave, Keras complex, a T wave. All the P waves are married to a Keras complex. We count our PR interval, it's about 5 small squares. You can actually go backwards the video and actually count the PR interval. You see that it's 5 small squares. So it's a normal and it's constant. It's 5 small squares throughout. Borderline, almost borderlining a prolonged PR interval, but it's constant. So our Keras complexes are broad. As you can see, this one here is well over 3 squares. So it's well over 3 small squares, your broad Keras complexes. We look at our cardiac axis. Lead 1 is facing upwards, lead 2 is facing upwards, lead AVF is facing somewhat downwards, if I could say this is facing downwards. So lead 1 and lead 2 are facing, lead 1 and lead AVF are facing downwards, but lead 2 is facing upwards. So it's a left axis deviation, but it's not significant because lead 2 is facing upwards. So you can say that maybe this is a normal axis. We look at now for any bundle branch blocks, we can see that in lead V1, we can see this rabbit ears, the RSR prime pattern. We can also see it much more prominently in V2, RSR prime pattern in V2. We can also see it in V3. And then when we come now to V4, V5, and V6, as we can see, there's slurring of the S wave. There's slurring of the S waves that we can see here, slurring of the S waves. We can see. We can also see that there's a bit of some symmetrical T waves. Remember, if we see any symmetrical T waves, that's usually a problem. We can also see that there's some inversion of the T waves in lead V1, V2. We can also see inversion of the T waves in lead 3. So you can see that there's inversion of T waves in lead 3 here. I'm not going to comment on hypertrophy or ischemia or infarction yet because we haven't yet done those concepts. So what is our interpretation from this ECG? This person has a sinus rhythm to begin with because P waves are present, rhythm is regular, your P waves are married to a QRS complex, your PR interval is normal. Number one. Number two, they have broad QRS complexes. So meaning that it could be a problem, either the rhythm is being blocked somewhere or it's being delayed somewhere. Most likely it's being delayed in the conduction system. So it's most likely this patient has an isolated right bundle branch block. They have a right bundle branch block with sinus rhythm and broad QRS complexes. Coming to the last ECG, pause the video, interpret the ECG. Now you should be coming close to being a master now at picking up these pathologies. Once you watch the remaining videos, which I think I should remain with talking about left bundle branch block, then we need to talk about the hypertrophies, which are 2 more videos, and then we'll talk about ischemia, which is 2 more videos. So you should be left with about 5 more videos to watch, and then you should be done with interpretation of ECG. Then afterwards, we shall look at examples, many different examples where you can actually test yourself, and then we'll also look at the different abnormal rhythms that are there in terms of the ECG and cover these different rhythms so that you can be able to pick up these pathologies on the ECG. So here comes the answer. So as you can see here, we don't again have the ECG details. The normal calibration is there. We can see 1 big box and 2 boxes tall. We can see that there's some ugly morphologies of the ECG here. Is it regular? If we measure the distance from lead 2, which is in our rhythm strip here, so this distance is equal to that, is equal to that, is equal to that. The P waves are present, QRS complex, T wave, P wave, QRS complex, T wave, P wave, QRS complex, T wave. So there's a regular rhythm, it's a sinus rhythm. If we actually measure the distance from here to here and calculate the small boxes, you have about 27 small boxes. So 1/5 divided by 27, you get 56 beats per minute. So if your P waves are present and they are normal, your PR interval, if you count here, it's about 4 boxes and it's constant. Your QRS complex is narrow. If we're looking at lead 2 is here, it's narrow, so meaning it's within 3 small boxes. Your cardiac axis, lead 1 is facing upwards, lead 2 is facing upwards, lead AVF is facing upwards. Predominantly, I don't know what's happening at lead AVF here. This is a normal cardiac axis. We look at V1, V2 for any bundle branch blocks, as well as V6. So V1 and V2. So in V1, you have the RSR prime pattern. You have it also in V2. You also have it in V3. And we have the slurring of the S waves in lead V5 and V6. In terms of the RS wave progression, all the QRS complexes in lead 1, 2, AVL, 3, and AVF should be facing upwards, but we can see that in lead 3, it's facing downwards. Even in the precordial leads, V1 and V2 should be predominantly facing downwards, but they are not. V3 and V4 should be equidistant, they are not. V5 and V6 should be facing predominantly upwards, they are. But here there's a poor RS wave progression because we don't see the changes we're supposed to see in V1 up until V4. So there's a poor RS wave progression. So you can also see additionally that there's inversion of the T waves that we can actually see in lead V1. We can see that there are these inverted T waves in lead V1. We can't comment on hypertrophy yet. We can't comment on ischemia yet. So this person here has a poor RS wave progression. They have a sinus rhythm. They have a right bundle branch block. Most likely they have an isolated right bundle branch block. Normal cardiac axis in this particular patient. So that's how you would interpret this ECG, and that's how you would actually work through these ECGs, and you should be able now to have an idea or be building up on your concepts and understanding the ECG. I really hope you enjoyed this video. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.